So it's my pleasure to introduce our next speaker, Dr. Nestor Tomycz. Dr. Tomycz was raised in Flint, Michigan. He graduated from Harvard College, summa cum laude in chemistry, and earned his MD degree from Harvard Medical School. He went on to complete his neurosurgical residency at the University of Pittsburgh Medical Center with a one-year inter-residency stereotactic and functional neurosurgery fellowship at Allegheny General Hospital. He joined the faculty at Allegheny General Hospital and has since focused his practice on chronic pain, spasticity, DBS for movement disorders, peripheral nerve stimulators, spine tumors, spine trauma, as well as degenerative spinal disorders. He is currently director of the Neurosurgical Pain Division, as well as stereotactic and functional neurosurgery at Allegheny General Hospital. He also serves as chief of neurosurgery at St. Clair Hospital in the South Hills of Pittsburgh. Dr. Tomycz is actively involved in clinical research involving deep brain stimulation, spinal cord stimulation, and spinal fusion. He is actively pursuing the use of deep brain stimulation for new indications, such as opiate addiction. He has published over 50 peer-reviewed manuscripts, as well as multiple book chapters and technical manuals. Today, Dr. Tomycz will be giving a talk on neuromodulation and movement disorders. Please feel free to type any questions you may have using the Q&A function throughout his talk so that we can try to address them at the end of his talk during the Q&A portion. Without further ado, I'll let Dr. Tomycz start his presentation.
Good morning, Josh. Thanks everyone for calling in. Can you hear me okay?
Yes, we can hear you, and we can see your video right now.
Okay. I'm going to try to share a PowerPoint here, and let me know if this comes up okay. Oh, that's not the right one. Can you see that all right?
We're still just seeing your video.
I need to click share probably here. Share screen. Okay. How's that?
Yep, we can now see your screen and we can still hear you. I think you're good to go.
Thanks for the introduction, Josh. Like I said, I'm happy to make this as interactive as possible. There's been a lot of great questions for Dr. Whiting already, but like I said, we want to make this valuable and interactive, and I'll try to answer as many questions as I can and not be too redundant. Dr. Whiting gave a very good overview of functional and stereotactic surgery, the history. I've been kind of asked to talk a little bit more about the movement disorders and neuromodulation for them. Something that I have a big passion to do both in the clinical arena and research. And it's a very exciting field. It's great that so many medical students are interested in neurosurgery, and especially in this subspecialty of functional stereotactic surgery. It's kind of become more and more of a need for every hospital in the country, where before kind of functional neurosurgery was concentrated in certain academic centers. More and more the technologies have improved, and the training has improved, and like I said, more and more hospitals across the country want someone that focuses on movement disorders, chronic pain conditions, epilepsy. It's not just a kind of level 1 university hospital problem that is concentrated now. So it's an exciting time if you're interested in this field. It's really among neurosurgery. I'm biased, but like I said, if you look at neurosurgery, there's tumor and vascular and spine, but I would say some of the most intense innovations going on in neuromodulation and functional stereotactic surgery, because it's so Sorry, can you hear me okay?
Yeah, we can still hear you.
Okay, just double checking. Like I said, I'll try not to be too redundant. We're going to kind of go through some things again here. So what is neuromodulation? Like I said, the International Neuromodulation Society kind of defines it as technology that acts directly upon nerves or the nervous system, and either by electrical or pharmaceutical agents to modulate neuronal activity. Neuromodulation for movement disorders, you can pretty much put into 3 categories for the most part today. Deep brain stimulation is really the main one, and the main one I'll talk about. But like I said, there is some neuromodulation for movement disorders that's not DBS. One is intrathecal baclofen. And intrathecal baclofen has been around for at least 30 years and can be very effective for the movement disorders, spasticity and dystonia. And there's also spinal cord stimulation, which is, like I said, a neuromodulation technique that's been around since the 1960s for chronic pain, but there is some early evidence that it could be effective in movement disorders. I'll talk a little bit about that, something that I do a lot of. So like I said, movement disorders, they can be kind of broadly separated into the hypokinetic one, where you have a paucity of movement, or the hyperkinetic movement disorders, where you have excess movement. Sometimes you have a combination, like Parkinson's disease, where you have hyperkinetic tremor, but you also have bradykinesia, or slowness of movement. The main movement disorders that I'll be talking a little bit about are Parkinson's disease, essential tremor, dystonia, and spasticity. So essential tremor, like I said, this is the most commonly diagnosed movement disorder. So millions of people worldwide. Once patients get up to age 80 or more, the prevalence can be as high as 10%. There's a very strong family history in patients with essential tremor. They often tell you that their father or mother had it, their uncles have it, and like I said, it's usually just a single symptom, tremors, this disease. Typically, the patients have involvement of their extremities, but their voice, head, jaw, lips, and face can also be involved. And in most cases, it's what's called an action tremor. It's worsened by movement. So when patients are reaching for a target, the tremor amplitude increases and worsens. It can also be a postural tremor when they hold their hand out against gravity. But like I said, it's a contrast to Parkinson's disease, where you usually see more of a rest tremor, a pill rolling tremor when the hand is held kind of like on the thigh. It's not with action. So very common disease. You'll often see people out and about with this disease, and primidone and propranolol are the main medications that people are treated with. I believe propranolol is only FDA-approved medication, but the response is not great. At least 30 to 50% of patients may not respond to medications. Now, it's very important to note that essential tremor is a disease that often does evolve into something else. So we deal with this in the clinic all the time. We see a patient that's referred for essential tremor, perhaps to be treated with deep brain stimulation, but they may have features of Parkinson's disease when we examine them. It's been shown that if you have essential tremor, you have an increased risk of developing Parkinson's disease by 4 to 5-fold. You also have an increased risk of developing Alzheimer's disease. So essential tremor is truly a neurodegenerative disorder. And once again, there's like an overlap. There's like a Venn diagram where some of these patients actually, even though they look like a pure kind of tremor disease, may eventually develop full-blown Alzheimer's or full-blown Parkinson's disease. So like I said, there's some overlap in these neurodegenerative disorders. They're hard to diagnose. There's no blood test for essential tremor. It's a clinical diagnosis. And we rely really heavily on our movement disorder neurologists, who specialize in seeing these patients every week and day, and are very good at making that diagnosis. The picture on the right just shows you a kind of an Archimedean spiral. These are kind of a kinetic test that you can do to really bring out the tremor in patients. And we also use it to see the response to deep brain stimulation. So as Dr. Whiting kind of mentioned, DBS has been approved for essential tremor since 1997. The primary target is that BIM thalamus, but there are other targets such as the zona incerta that could be considered as alternative targets. DBS is a very effective therapy for these patients. There are some side effects with DBS, such as dysarthria, gait instability that can happen. The long-term efficacy may be lost in some of these patients due to disease progression. So once again, it is a progressive disorder. Sometimes patients begin with tremor in one or more extremities, and then it progresses to the other extremities or to the face, the voice. And so once again, one of the beauties of DBS is that it's a programmable therapy. So once again, when you have a progressive disease process, it's great to have an adjustable, programmable implant that you can kind of tune to try to recapture symptom control. And we tell patients this is a moving target, whether you have Parkinson's disease, essential tremor. These diseases progress, so you might be okay on your settings for some time, but the disease will get worse. We don't have evidence that we can stop the progression yet of these diseases. The only thing that might slow down the progression is exercise, which has been shown to have a particular benefit in Parkinson's disease. Dystonia is another disease of movement that we treat with deep brain stimulation. Dystonia is characterized by involuntary muscle contractions, and these can cause slow repetitive movements or abnormal postures. It's a much more rare disorder than essential tremor and Parkinson's disease. It can be focal, involving just the hand, like a writer's cramp, as you see in the upper corner there, or it can involve just the neck and cause torticollis, or it can be a generalized dystonia that involves the whole body. It can be very debilitating. Dystonia is often diagnosed early in life, and it has a very strong genetic component. There's multiple gene loci that have been linked with dystonia. One of the most notable ones is the DYT1 locus, which that defect, when patients have dystonia, they have a generalized dystonia that begins early in life in childhood, and they're particularly have a good response to deep brain stimulation of the globus pallidus. So more and more, when patients are being diagnosed with movement disorders, I think we're getting better at getting genetic studies, and the cost of doing that and doing genetic analysis has come down. And once again, instead of kind of classifying patients as symptoms, like I said, if you look at the literature and people are kind of lumped together with symptoms such as cervical dystonia, but I think one of the future things in neuromodulation more and more will be studying patients kind of with particular genetic defects, like studying just cervical dystonia patients with a certain DYT mutation with DBS. So kind of, right now it's a very heterogeneous group that's based on symptomatology, but really using genetics to identify the best candidates and to guide the best treatments is part of the future here with movement disorders. Dystonia is treated with medications such as Artane. It's treated with Botox. Intrathecal Baclofen has some benefit, but really the best treatment for dystonia is deep brain stimulation of the globus pallidus interna. And like I said, it's very effective in the DYT1 mutation subgroup of generalized dystonia. The globus pallidus is a larger target than subthalamic nucleus, which is often used for Parkinson's and the VIM. So you often need high stimulation parameters in patients with dystonia. What does that mean? Well, I mean, you need more juice, you need more electrical energy to get clinical benefit. And that's important because, like I said, that will dictate what kind of technology these patients are implanted with if you do deep brain stimulation, because they require higher energy requirements. They might require more frequent battery changes, so they might be, like I said, a better candidate for a rechargeable type system. So one of the curious things about dystonia when you do deep brain stimulation is it may take many months to see the full clinical benefit. And this is quite a contrast to deep brain stimulation. When we do Parkinson's disease or essential tremor, when you turn the deep brain stimulation device on, you often see improvement in the tremor or the rigidity right away within seconds to minutes. It's, once again, you might have seen commercials of patients undergoing deep brain stimulation, and you usually choose a patient that has a tremor, and you turn it on and the tremor slows down before your eyes. It's one of the most dramatic things in medicine, in my opinion, for some of these patients. And dystonia is different. It's not like you just turn it on and you see the benefit. When you're first programming these patients, you often have to wait many months. So like I said, it probably works a little bit differently in the brain than DBS for the other movement disorders. It requires more plasticity to happen. That's why you often, it takes sometimes months to see the full benefit. One of the universally used grading scales for dystonia is the Burke-Fan-Marsden Dystonia Grading Scale. I only mention that because I think it's very important to kind of point out why is neuromodulation, such as deep brain stimulation, why has it been so focused on movement disorders? The history of DBS, like Dr. White talked about, actually was actually designed for pain. And when Medtronic first coined the term DBS and designed the technology, when they adapted the pacemaker technology from hearts to the brain, they were hoping to use it for pain. And the FDA kind of took over medical devices in the 1970s, and it really changed the way devices were regulated, and it really required devices to be more stringently evaluated as far as efficacy like they had never been before. And movement disorders kind of fell naturally into that stringent criteria for devices because you had kind of universally used quantifiable scales for movement disorders. For Parkinson's disease, we use the UPDRS, the scale that's used for measuring not only the quality of life problems, but the motor problems of Parkinson's disease. For dystonia, you had the Burke-Van-Marsden scale. So once again, diseases that have a good metric system for studying their outcomes are diseases that have been targeted for deep brain stimulation historically. Pain was much more difficult to do that. Pain is hard to quantify, and that's why diseases like pain, depression, schizophrenia, obesity, these are some of the other diseases that could be benefited with DBS have been harder to study because we don't have the same rating scales. But we have very quantified rating scales for movement disorders, and that lent itself to doing studies and getting the FDA approval, which is necessary for these expensive devices. Going on to spasticity, this is a very common movement disorder in patients with any kind of brain injury, whether you have a stroke, spinal cord injury, cerebral palsy patients, multiple sclerosis. But spasticity is kind of a result of upper motor neuron lesion damage. If you get an upper motor neuron damage from injury of any type, whether it's autoimmune or trauma or congenital, the body often manifests with spasticity. Spasticity is a velocity-dependent increase in muscle tone. It's often graded with the Ashworth scale. But spasticity is a very common movement disorder that we see especially in kids with cerebral palsy, but also in adults with brain injury, spinal cord injury, multiple sclerosis that can benefit from neuromodulation. So intrathecal baclofen, Dr. Whiting talked a little bit about pumps, but pumps implanted under the abdominal wall that can deliver baclofen into the CSF space have been around for a couple decades now for spasticity and have great benefit for these patients. Patients with severe spasticity can be very difficult for caretakers to take care of, to address, and oral medications like baclofen often don't penetrate the blood-brain barrier well, and you're not able to get great relief of spasticity with oral medications alone. When you deliver medications intrathecally, you bypass the blood-brain barrier, you can get much more clinical benefit from spasticity without the side effects. And baclofen is a GABA B agonist. Moving on here, so like I said, baclofen can be used for severe spasticity, is usually used for that, but you can also use it for dystonia. One of the downsides is baclofen, when delivered intrathecally, your body gets used to it, and you can have withdrawal symptoms if the pump stops or malfunctions that can be life-threatening. You also have to be under the care of a specialist to understand how to dose this medication and make sure that the pump is refilled. Because like I said, it's a very powerful medication when delivered intrathecally. Too much or too little can cause severe life-threatening problems. And it can only be delivered with a programmer under the expertise of a specialist that follows these patients very closely. So I'll briefly mention, once again, this is not FDA approved. This is not something we're doing every day in any way, but I do think spinal cord stimulation, which has been around since the 1960s for pain, will start being used more and more for movement disorders in the future. I think one of the things we found with DBS is that it doesn't have consistent benefit for gait in patients with Parkinson's disease. So once again, DBS for Parkinson's is very good for tremor, bradykinesia, dyskinesias, which are the abnormal involuntary movements that you see in patients. Like if you see a video of Michael J. Fox, and it seems like he can't stop moving, those are dyskinesias. And DBS is very effective for that. But if a patient comes to you with Parkinson's disease and their main complaint is their walking or their gait, DBS, it's harder to predict how good that outcome will be with DBS. So like I said, some people are looking at other targets in the brain. The pedunculopontine nucleus in the midbrain is a new target that's being explored for gait dysfunction in Parkinson's disease. But spinal cord stimulation, which has been around for 40 years now, has been shown in both animal studies and in some human studies to improve walking and freezing in patients with Parkinson's disease. It can even improve posture. If you look in the picture on the right, some of our patients with severe Parkinson's develop what's called camptocormia, which is an abnormal hyper-exaggerated flexion posture at the thoracolumbar junction. And spinal cord stimulation may have benefit in these patients. So once again, it's something that's only been done in small studies, kind of off-label. But once again, I think spinal cord stimulation, which is a well-established neuromodulation technology, is slowly going to be more utilized in patients with movement disorders such as Parkinson's disease, because there are some limitations to DBS, like gait, that we just can't do as well with DBS alone. So I'm not going to go too much into the history here because Dr. Whiting did, but I'm just going to talk more about brain stimulation because that's the main neuromodulation that we do for movement disorders. So like I said, there's many different kinds of brain stimulation. The one I'll be talking about is the invasive deep brain stimulation. But there's ways to stimulate the brain, such as transcranial magnetic stimulation without making any incisions or putting any electrodes in the brain. This uses induction, and you can use direct cortical stimulation as well. Next slide there. So I know some of these are a little redundant. Dr. Whiting went into this, but there's now multiple companies designing technology for DBS. Once again, most of the electrodes are platinum iridium. These are very narrow diameter. Most of the electrodes that we're placing in the brain still have a common design of 4 contacts. The newer technology, these middle contacts are sub-segmented into directional leads. So basically, the middle 2 contacts are subdivided into 3 at 120-degree angles to each other. So you can kind of turn cathodes on in certain directions. So instead of just making torus or spherical electric fields in the brain, with the directional technology that's coming out now, you can kind of focus electricity in certain directions. So that's newer technology that's also hopefully leading to more efficient DBS, less energy usage, and less side effects. So like I said, Dr. Whiting went over these slides before, but once again, currently DBS is approved for the Parkinson's disease, essential tremor, and dystonia movement disorders, which I talked about. It is also approved for epilepsy and obsessive compulsive disorder. There's a number of diseases that are being studied. Dr. Whiting talked about obesity and Alzheimer's, which I'm involved with, but addiction is another one that I'm very excited about that I've been working on. We do now have FDA approval to do deep brain stimulation for opioid addiction, which has been done in small amounts across the world. It's been done for alcohol addiction in Germany. It's been done for opium addiction in China and heroin addiction. We're asking for FDA approval for opioid addiction, opioid use disorder, and we're hoping to do an implant within, hopefully still this year, for that type of patient. We have the right addiction team behind us, and but like I said, to do anything in the brain that's not approved, it takes a lot of work. You need to go to the FDA, and this technology is expensive, so you can't just do it off-label. Like a medication you can give off-label for another reason, but you can't just take someone to the operating room and do brain surgery for another reason. So the epidemiology, Parkinson's disease is the second most common neurodegenerative disease. There's about 1.5 million people in the United States per year. Men are more common than women. It does seem that there are some things that reduce your risk. Cigarette smoking, coffee and tea, alcohol may decrease the risk. Family history is a risk factor. Head injury may increase the risk slightly. And like I said, Parkinson's disease is a very complex disease. It's not just a movement disorder disease. There's a lot of non-motor symptoms, and definitely those affect quality of life. Part of when we treat patients with DBS, it's very important to kind of sit down with them and get to know them well and say, what's affecting your quality of life the most? If a patient says that their quality of life is most affected by swallowing problems, then once again, DBS, we can't promise we'll help that in any way. So there's a lot of symptoms in Parkinson's disease, and oftentimes patient symptoms start years before they're diagnosed. They might think they're just slowing down because they're getting older. Their handwriting might change and get a little floppier and smaller print. And sometimes the spouse picks up on that more. But once again, once people are finally diagnosed, they've often had the disease for many years and it affects many body parts. So the pathophysiology, I'm not going to go too much into, but obviously degeneration of the substantia nigra, dopamine neurons. The pathologic hallmark is Lewy bodies. These Lewy bodies are seen not only in the substantia nigra, but throughout the brain. Next slide here. So the pathophysiology, once again, I'm not going to go too much into, but more and more, I think there's evidence that oxidative stress is important. The proteasome and protein degradation is very important in the pathophysiology of Parkinson's disease. Right now it's still a clinical diagnosis, but once again, I think genetics and genetic studies, as they become more widespread in medicine, are going to, identify subtypes of Parkinson's, and then we're going to have better strategies for treating those subtypes based on DBS or medications. Right now, it's a clinical diagnosis, and like I said, people have very different phenotypes. Some Parkinson's patients have no tremor at all, and some patients are tremor-predominant Parkinson's patients. So once again, we lump them all together into the same Parkinson's disease category. We treat them all the same, but once again, I think as we do genetic studies and understand more about the genetics behind these movement disorders, we'll have more targeted treatments. So there are young onset Parkinson's disease patients. Most patients are older in their 60s, but we do see patients younger. And once again, it's a different phenotype. There's more likely to be genetic predisposition in these younger patients. They seem to have more dystonia. Dystonia can be part of Parkinson's disease as well. So like I said, many of these young patients that we see who are in their 40s or 50s with Parkinson's, they have a gene defect in the leucine repeat kinase 2. And once again, they're often better candidates for surgery like DBS because they're younger, they're not on Plavix, they don't have medical problems that sometimes older patients have. So some of our best patients are younger, and we've treated many of those patients with DBS with success. So I know Dr. Whiting covered the history, so I'm not going to cover too much of this. And once again, I just want to talk about the advantages of DBS for movement disorders. It's non-ablative, does not destroy tissue. They've done post-mortem studies on patients with DBS, and you see some gliosis around the electrode, but you're not cooking the brain cells, you're not killing the brain cells with DBS. Chronic electrical stimulation over decades does not lead to damage of the brain that can be seen on autopsy studies. So it's reversible, you can turn it off, you can remove the DBS, and most importantly, it's titratable. Like I said, DBS, can deliver tens of thousands of different flavors of electricity to the brain. We can shape the electrodes now, we can shape the electric field now because of directional leads. So once again, just like dosing medications, we dose the electricity for these patients, and it's a moving target. As their disease progresses, we can change the dose and continue treating them. And that's one of the big advantages. There are ways to lesion the brain, like Dr. Whiting mentioned, with radiofrequency, gamma knife radiation, ultrasound. So there's different ways you can make lesions in the brain, and you can often do that with, and lead to some improvements in the movement disorders. But when you lesion the brain, what you get is what you get, and you do lead to brain damage that, once again, could have a side effect that is irreversible. So we still feel that brain stimulation is kind of way superior than lesioning. Ironically, stimulation was initially done just to help people do lesioning, but that was in the 1940s and 50s, and there was no implantable technology then. So they didn't have a way to really leave an electrode in the brain and connect it to a battery. That technology wasn't available yet. So basically, stimulation was done just to test, are we in the right area before we burn the brain? But now, once again, we really don't try to burn the brain much at all for movement disorders, unless the patient just can't have DBS. Like if they're on a blood thinner that can't come off the blood thinner, they might be referred for a lesioning procedure like gamma knife radiosurgery. So once again, we don't know how DBS works, but most of our current research we do think it's related to pathological oscillations. DBS seems to work in multiple locations throughout the brain. So once again, if you work within the network of pathology with DBS, you can get benefit. And once again, one of the future potentials of DBS is the program itself. Right now, you have to drive into clinic, have your DBS programmed by a specialist, and but we'd love if the DBS could eventually program itself. There's different ways of doing that closed loop stimulation. One way would be from brain signals themselves to be recorded and to program the DBS itself as it works. So you can imagine a patient with tremor. Somehow the DBS is listening to a signal in the brain and programming to stop the tremor at the same time. Or another way to close the loop would be to have someone wearing like a wearable sensor on their wrist that transmits the tremor information back to the DBS device and also changes the way it delivers electricity. But like I said, closing the loop has still not been done yet for DBS movement disorders. So I'm going to move on here a little bit more. For our patient selection, like I said, we look for patients who have idiopathic Parkinson's disease. We want them to have at least 5 years of symptoms. If someone gets diagnosed with Parkinson's disease for just a year, once again, there's a lot of Parkinson-like mimickers. There's a lot of Parkinsonism. That's not Parkinson's disease. So sometimes people can be on medications for psychiatric disease, and they can look like they're developing Parkinson's as a side effect. So there's a lot of other reasons you could develop Parkinson-like symptoms. Before we rush to do DBS, we really want to make sure that the diagnosis is pretty solid as much as possible, and that's why we often wait a few years. The patients that benefit the most have dyskinesias, have on-off fluctuations, and we still want to see a benefit from L-DOPA, the medication that, once again, is the most effective for Parkinson's disease. It's important that they still have benefit. This is the frame that we're using currently at Allegheny General. This is a CRW frame. Once again, there's different ways to do DBS. There's frameless technologies, but the frame is still kind of the gold standard that everything else is compared against. Once again, Dr. Whiting talked about all the historic frames. The CRW is what we're currently using now. And like I said, it's a beautiful machine because it can allow you to hit a small target in the brain with sub-millimeter accuracy. And you can change, like Dr. Whiting talked about, you can change the entry point. So once again, this can swivel around the target and still hit the target. So once the target's fixed with the frame, the machine allows you to pick different entry points. So if you see a blood vessel or something you want to avoid when you're doing the surgery, you can move it over and you're not going to affect your target accuracy. So like I said, all our patients that we get MRIs of the brain under general anesthesia. The reason for that is we want to have a really good picture of the brain without any kind of tremor. And we do on-off testing. We have a nurse, Cindy Engel, who's been doing DBS patients evaluations for many years now, and she does an on-off test where she checks their UPDRS score. That's that standardized movement scale score I talked about. She sees how they look with their meds on and off, and we want to see a certain reduction. So we want to see a certain improvement with medications. And we also do neuropsychologic testing. Once again, dementia is part of all neurodegenerative disorders, essential tremor included, Parkinson's included. Once again, we don't want to do surgery on patients with dementia for a number of reasons, but like I said, we really try to identify if patients have dementia with formal neuropsychologic testing. So we have a neuropsychologist that sees these patients because, like I said, dementia is something that's hard to diagnose just by when you're meeting someone for the first time in clinic. Patients can compensate. And you really stress them a little bit with more formal testing and memory testing, pattern testing. You'll suddenly may identify dementia that you didn't recognize before. And if they have dementia, really, once again, we don't feel that they're great candidates for implanting DBS technology. When to perform DBS, once again, when DBS first came out, we treated the worst patients, late stage kind of Parkinson's patients, but there have been more and more trials of doing it earlier in patients, and there's economic reasons to do it early for improving quality of life years, reducing cost of medications. Once again, most of our patients that we implant with deep brain stimulation can reduce their needs for medications, and that's a big deal. A lot of these patients are kind of really anchored to their medications. They're taking them 4 or 5 times a day. When their medications are wearing off, they freeze up. And DBS really can smooth out the motor control throughout the remainder of the day. The best candidates are younger. They have a good response to medications. They have dyskinesias, motor fluctuations. Once again, the cardinal motor symptoms: tremor, rigidity, bradykinesia, and then reasonable expectations. Once again, expectations are very key when you do surgery of any type, but once again, DBS especially, you have patients who have a non-curable progressive neurodegenerative disorder. So it's very important that we point out this is not a cure. Once again, the outcomes can be quite dramatic and life-changing, and patients, some of our happiest patients are DBS patients. However, once again, expectations are important, not only the patient's expectations, but caretaker expectations. And we spend a lot of time getting to know these patients and their families to make sure that they realize that, once again, it's a moving target, and as the disease progresses, they might need more medications, they might need more reprogramming of their DBS, and unfortunately, we still don't have a cure for this disease. The surgery itself, like I said, Dr. Whiting and I still do it in 2 stages. We do the first stage awake, and we place the frame on patients awake, and they get a CT scan. We fuse that CT with the MRI. We still do microelectrode recording to listen to the brain cells to help give us an electric kind of signature of where we are in the brain, to give us comfort that we're in the right area. And most of our patients stay overnight for the first stage. The second stage, we place the batteries asleep, and we send them home the same day or either to rehab. Once again, there's different targets in the brain for DBS and Parkinson's disease. The primary target we do is the subthalamic nucleus. We usually target this bilaterally. It's a small target. It's nice because you can really identify it by microelectrode recording. And one of the main benefits of subthalamic nucleus DBS is that it can reduce medications. Once again, the medications in Parkinson's disease are great early on. Once again, if you've seen that movie Awakenings, you remember how dramatic it was when doctors first started using L-DOPA. Now that patient in Awakenings isn't a Parkinson's patient, but once again, when L-DOPA came out in the 1960s, it was very dramatic. You had people that were frozen up in nursing homes that were suddenly moving and talking, and their loved ones hadn't had conversations with them for years. But once again, the downside is that the medications themselves in Parkinson's disease start causing problems over years. So people start getting medication side effects such as dyskinesias when they take them at high doses and for long periods of time. So DBS becomes a way we can start reducing needs for medications and hopefully protecting some of these patients from the side effects of medications down the line. The targeting, like I said, this is the subthalamic nucleus here. The globus pallidus here is targeted for Parkinson's as well. And then the VIM thalamus is a subnucleus of the thalamus that we target for tremor. Sorry. So the microelectrode recording is the way to listen to brain cells. Once again, in Parkinson's disease, the subthalamic nucleus is hyperactive. It has a chaotic pattern, sounds like popcorn, 50 to 70 hertz. And we listen to the brain cells. That's still the gold standard as well in DBS. There are places not doing any microelectrode recording anymore. But once again, you can use imaging to target the brain. You can use robots. You can use a lot of different technology. But sorry, let me catch up here. But the microelectrode recording is still the gold standard because, like I said, you're listening to the brain cells, you're listening to single neurons fire in the brain. And when we do the DBS surgery for Parkinson's, we like to see at least 5 millimeters that we've pith of the subthalamic nucleus. So I'm not going to go too much into the programming. The programming is complex. Once again, there's different technologies. Programming takes months because as you're turning the DBS on and programming, you're reducing medications, you're seeing the patients back a fair amount. So obviously, it's a labor-intensive process. There's no great AI that's been designed to help with DBS programming, but that's part of the future. Remote programming, when patients are at home and being programmed, their brains are being programmed, has been discussed, but that's not happened quite yet. And once again, closed loop may be a way that these devices can program themselves, because every symptoms are patient specific. So I talked about earlier DBS. Once again, more and more evidence is coming out that earlier DBS is better. Patients are younger and healthier, they recover more quickly. And like I said, by sparing medications, you may be able to produce more problems down the line for these patients. DBS risk-wise, like I said, for movement disorders is pretty low. In the scheme of what we do as neurosurgeons, compared to brain tumor removal and aneurysm clipping and other spinal surgeries that we do, DBS is pretty low risk. It's pretty minimally invasive when it comes to brain surgery. It's still an incision, it's still surgery, but it's, once again, we're not retracting the brain. We're not, we make small quarter-size openings in the skull that we cover up with plastic caps. And most of the complications we have are related to the hardware itself, infection or discomfort or fracture of the hardware. Fortunately, we don't see many hemorrhages, seizures, or symptomatic bleeding in the brain or symptoms in the brain from the DBS. So, and then there's stimulation-related side effects. So when you turn the stimulator on, you might get a side effect. But like I said, the stimulation-related side effects are often reversed just by changing the programming. So if someone says, hey, I'm getting some tingling here when you turn it on, you can often change the programming to avoid that. So what improves with DBS? Once again, DBS has been studied very carefully. I must say, I'm a little bit proud of functional neurosurgery in this sense because, once again, there is some dark history to what neurosurgeons were doing as far as psychosurgery and treating patients with lobotomies and different interventions. And obviously, like I said, it's kind of presentism to kind of look back and say that was all crazy, but obviously things were done to patients without kind of IRBs and without careful studies and controlled trials that is completely unacceptable now. And when DBS came out, I think neurosurgeons were very careful how it was studied with controlled trials, even having the device off, and sham studies were done. And once again, DBS has been studied to the highest level of medical evidence, which is kind of class 1 evidence. But you can't say that about a lot of other things in neurosurgery. But we really know that we can improve tremor, rigidity, bradykinesia, dyskinesias in patients. We can reduce their medications. The motor symptoms are clear. I like to tell patients that you can kind of smooth out the motor control. So there are patients with Parkinson's that have, a lot of fluctuations throughout the day. They wake up, they take their meds, they're moving too much because their meds are on. As the meds wear off, they start freezing up in the middle of the golf course. They can't move. They take their meds again. So once again, DBS can kind of smooth that out by giving continuous stimulation throughout the day. But like I said, it's not just motor symptoms. As doctors, we're really good at focusing on motor symptoms and saying, wow, your tremor's better, great. But once again, more and more the DBS field and medicine in general is focused on patient-centered outcomes. And once again, is the patient satisfied with it? Does it really improve their quality of life? Because you can, once again, it may surprise you, but you could have a patient that has significant reduction in tremor, but doesn't feel that this implant or DBS has significantly improved their quality of life. So you need to make sure that you're focusing on quality of life measures. And more and more DBS has also been studied with these measures in mind: activities of daily living, the social stigma of going out in public with your hand shaking or having masked faces. And more and more we're studying DBS and showing that not only it improves all these motor symptoms, we know that, but it improves quality of life. There's evidence that it improves caretaker quality of life. So once again, it's living with someone with a neurodegenerative disorder is very taxing, and showing how DBS can help the caretaker's quality of life by helping that patient become more independent is a big deal. Some patients experience weight gain. You can imagine if you're constantly moving, you're constantly burning calories. So many of our DBS patients are on the lower body mass index scale. They're, So if they're constantly moving because of dyskinesias or tremor, when you reduce that, you often see them gain some weight. We're showing that DBS can also improve sleep quality, architecture, and even pain. Once again, pain is a big part of these movement disorders. Patients with Parkinson's disease, the pain from being in certain postures, from constantly tremoring, can be very debilitating. And once again, more evidence has suggested that DBS can help pain as well. So what's the future of DBS? Dr. Whiting did a great job talking about this, but I'll give you my take on it. So once again, new targets are important. We're just kind of tip of the iceberg, what we're exploring in the brain. Now, most of DBS is kind of evolved from the lesioning era. So things that we used to lesion in the brain are now being stimulated. But like I said, obviously much of the brain has not been studied with stimulation, so it's the tip of the iceberg. There's a lot of new targets that are being explored. Like I said, the pedunculopontine nucleus is being explored for patients with primarily gait problems in Parkinson's disease. The nucleus accumbens is a target that I'm planning to treat for addiction. It's the center of the brain that receives a lot of dopaminergic input from any kind of pleasurable stimuli, and it's something that has been targeted in small numbers for different types of addiction with success. So we're going to do that for opioid addiction. It's very interesting. I don't have the picture, but it's even shown that they did a study out of with functional MRIs to show what lights up in the brain when young people look at social media and they get likes on their photos, but the nucleus accumbens lights up for that as well. But like I said, anything that is a pleasurable stimuli usually leads to increased dopamine release in the nucleus accumbens. That whole network is kind of hijacked by drugs of addiction, such as heroin and fentanyl, and leads to supraphysiologic release of dopamine. And once again, DBS may be a way to treat this. I think addiction is kind of a prototypical brain disease. When they were first studying addiction in animals, they found that if you could stimulate the addiction part of the brain, the animals would stop eating. They would just keep pushing the lever to get that stimulus at the brain. So once again, addiction is probably one of the most challenging brain diseases to treat because it's so hardwired. But I think DBS has a great potential, especially in the midst of this opioid epidemic. We have young patients dying every day from drugs of addiction. And I think as neurosurgeons, we're poised to really help this population right now. The hardware keeps improving, getting smaller, rechargeable, directional leads. Once again, energy is important. So we have people going into engineering, find us ways to extend the battery life, find us ways to even use the patient's own natural energy. The body produces heat and energy all the time. Can you use that energy to power implantable devices? That would be amazing. New modes of stimulation is huge. Once again, most of DBS has been square wave stimulation of the brain, but like I said, Dr. Whiting mentioned Erin Giddis. Her and I and Dr. Whiting were studying using kind of burst type stimulation in the brain and trying to find different ways to get better clinical benefit with less electricity. And once again, closed loop stimulation is going to be part of the future. We love that these are smart devices. We want smart devices implanted in humans going forward for neuromodulation. Devices that will, listen to the patient and modify how they stimulate based on the patient themselves. So we're not just open loop devices that are kind of dumb and just kind of fire without any kind of input. So that's really the future. But I'd love to take any questions you have here. This is kind of our team for DBS.
Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.